As I hope you will see from our presentation today, it is the people in this room and those who are watching live streaming or will watch this later who are the wind against our backs and under our wings that help us, particularly when the problem that we are searching, the answers we are searching for are not immediately apparent, but it is you who help keep us going because we know that we are accountable to you and that your hard work, whether it's giving money, time, or volunteering for our research, makes a difference. And I hope today's presentation will help you just get a glimpse. This is not all about SCAD, and it's not, we're not taking a deep dive into the science, but we want to give you a taste of what we're excited about and maybe what's around the corner. A number of you asked, what's really new, what have you found? And I think we'll show you some of that. I think what you'll see is how hungry we are to be able to take it to the next level, because there has been so much difference between, well, 5 years ago when I first came here and gave a presentation. We already knew some new things then, but the unlocking of the potential for understanding this condition, the connectedness with other conditions, which is brought in, I'll show you many new collaborators, many who are here today. And I think what also is Mayo has come around this. You know, my secretary, Cindy Allen, maybe you met her, she's come to several of the walks. This may be her last one because she got a promotion. She's not my administrative assistant anymore, but she and her husband Dave came and walked today. We've got her, I want to make sure, most of you met Jill Boyum, she's sitting there, raise your hand. We also brought, since last year, we have developed a patient ed brochure. We brought several boxes of them that we don't want to take back. We want you to take a stack of them so you can share with family, friends, or even your docs. So today, I wanted to acknowledge all the folks in the room. So Marysia Tweet, if you've been here before, you've met Dr. Tweet. When she was here last year, she was pregnant, but no one knew it. But she brought Rebecca with her this year. Dr. Tim Olson, who spoke a couple of years ago, and Jeanne Theis, who will be presenting on some of the genetics, and we're really excited to hear about that. And then Kevin Cohoon, who is one of our new Mayo Clinic staff, and he is going to be taking over, well, has already taken over some of the vascular, as we discovered that there were vascular issues often associated with SCAD that we need to really study in more detail, so we're working in close partnership. So I'll start. I'm going to, so this is where we came from, and it was sunnier there, right? That's our plumber building. I don't like to ever start a talk without talking about heart attack symptoms. Not everyone has everyone, but many of you called 911 right as soon as you had it. Others, the symptoms were not clear. You Googled these. So take this back to your sisters, mothers, daughters, husbands, and everyone. So most people will have some type of chest pain or discomfort or pressure. Not everyone, and in fact fewer women have that. But men and women's symptoms are not dramatically different, huge overlap. I think that's really important. That classic Hollywood heart attack, that doesn't happen that often to men either. So people will have chest discomfort, but it can go other places, jaw, arm, down the, kind of anything above the waist. Be concerned about it, particularly if it's associated with shortness of breath, lightheadedness, palpitations, a feeling of really unwell, and women may be more likely to get nausea and vomiting when they're having a heart attack. But I think the important thing is know these lists. They often happen in combination, and don't Google dial. That's my public service announcement. So I think all of you know in this room know that SCAD is different. We're going to talk about some of the things that it is, but it must be evaluated and managed and researched differently, which is why we're here, all of us. So this is a cartoon a bit of showing what atherosclerosis might look like. So what you see here is as that plaque and that gunk within the plaque, that's a really technical term, grows over time, and then the plaque ruptures. And when the plaque ruptures, it's exposed and a blood clot forms on top of it, blocking the artery, causing a heart attack. So SCAD's different, because what happens, you see a very normal lining of the artery, again a cartoon, that splits. Now this isn't exactly what happens, but you see it splits and you can have blood going in 2 different ways. And so sometimes on an angiogram we'll see this little line, a linear structure that we'll show you later. And then sometimes there's what we call an intramural hematoma, where a blood clot forms, even if there's not a split. But that too can block the artery and cause a heart attack. I also wanted to show that, our story is your story. It was survivors who came to me and asked, what's Mayo doing research on SCAD? And, actually in 2009, we really weren't doing much in the way of research on SCAD. And it was knowing that research was possible because of survivors who could, and developing with Dr. Tweet, a way to have a virtual registry so people didn't have to come to Mayo Clinic. We could get people from England and Australia involved. That's kind of that story. And then I'd say everyone in here is an e-patient, equipped, enabled, empowered, engaged. And so that's where often the rare disease community, and we have to call this a rare disease, but it's just uncommon, not rare. And that's where you all come in. It did get covered in the Wall Street Journal, which helped us a lot. I wanted today, I presented a little bit of this at the last fall in Carlsbad, and I thought it would be helpful because I get a lot of questions about what is the research that we're doing. And so just to divide some terms, one is really important, but what is a registry? So there's different types of research. Some you just review charts, you go back and look at it. Some you do a clinical trial where you might take 2 different treatments and then you test them on 2 groups of patients. We aspire to being able to do that for SCAD. A registry is where we collect all people with a certain type of condition, and then we study certain aspects of it. So in our case, it can tell us what happened in the past about those people who sign up for the registry, but it doesn't tell us a lot about people who aren't part of the registry. So that's where getting more people in the registry, all different, including men, is really important. It can answer things about what is connected to SCAD, but it can't necessarily help us with what's the best treatment. So that's that next step. So the registry is, for many diseases, is foundational. It gives us hypotheses or new questions that then we can test through research by doing clinical trials. And that's really what we're doing. So we also then have, screen back here, the DNA biobank, and you'll hear a lot more about that, but that too is kind of a registry / biobank. I think the other question people have asked about either the registry or their DNA when we test it is, will they send me my results? And so this isn't a clinical test, so we are building on that registry. So say you signed up for the registry 3 or 4 years ago, and now you've had another angiogram, or you've had a baby, or whatever. We want to hear, because we will build in your file that registry that will help round out the things that are valuable. So speaking of that, so we've got this virtual multi-center registry. We're almost at 600 individuals, and we have a number of angiograms ready to be read that will put us over the top, I think, pretty soon. So we look at all of the pictures that you send, angiograms, CTs, all of that. We look at it, for those of you who filled out the questionnaire, it's pretty extensive, but it helps us because it helps us generate those hypotheses and see how you are different or the same as other people who have SCAD. And then we've asked you to do a personal SCAD narrative. The reason for that is Dr. Tweet and I came up for that because it's one thing to have you come to my office where I can ask you questions and take down a history and write it in your Mayo Clinic chart. But it's only you. But if I just review that your doctor did at the time of your heart attack or in office visits, that doesn't put all the things that went on in between. You know that. So that helps us. What were you feeling, thinking? Because when I record what a patient tells me, I may not be 100% accurate, neither were your doctors. And so our plan is to continue to follow up, so you may hear from us again. I wanted to show you this impressive list because these are all the people who have, not all actually, who are actively or have contributed to some type of SCAD research in the past year. And so we've got our core team there, Dr. Vest, who was here last year. We've got our study coordinators in nursing, we've got radiology, we've got people in training, we have psychologists, we have OB-GYN, We have some folks who are doing rehab and pathology. An emergency department this year just submitted about how to best look at SCAD in the ER. And then folks from far away who have been participating with us and publishing with us. So a lot of folks at Mayo and people who are connected to Mayo that are working on this. So this was our first study that we published. This was on 12 patients. That was just Dr. Tweet and I figuring out if we could do this and if you could do this, if getting folks from all over the world. And I wanted to show you just a few snapshots of some of the things that in the past few years. This publication was voted most impactful of the year when it was published. It also, by the readers, most read, and also has been the foundation of understanding a lot of things about SCAD. It was built upon, again, you see Dr. Tweet's name as the first one because she's done a lot of the heavy lifting, but looking at treatment. This particular study is quoted a lot because it really gave us the reason why we should not be rushing in and doing a stent or a balloon on every single patient who has a SCAD. That in fact, waiting might be better for the patient. We'll talk more about that. This is about tortuosity. This is about using CTs, more CTs and FMD, review articles, rehab, inheriting SCAD, multi-vessel SCAD, familial association, depression and anxiety, because that's really important, pregnancy. And then this is a big, we're going to see some images from this. We were asked by, it was great to be invited, because usually you're invited by a medical journal to write something if you're viewed as one of the experts. And so Dr. Tweet was invited to provide this and put this together. So we're going to show some images of this. But this is showing all of the different ways that pictures, medical pictures, can help us diagnose and treat SCAD. So many of you know this, but I know that there are some people who are new to this, so having some more pictures. So this is actually at the patient end. So that would be sort of a normal artery. That would be where you have SCAD with a flap. This here would be that intramural hematoma. So there's still a split between the lining of the arteries, and it looks like a bulge, and could bulge all the way into the artery and cause a lack of blood flow. I think this is atherosclerosis, so that's what we are often differentiated in. If you can imagine doing an angiogram and only seeing the lumen, so seeing the lining, and then this, you can see how they might be mistaken if you only had the angiogram. So that's kind of building the case for why sometimes we have to do additional imaging. This is also showing SCAD. That's that intramural hematoma. This is the blood vessel. And you see this little ropey looking purple thing? That's actually a completely normal lining of a blood vessel that's being smushed by having that hematoma. So this is SCAD as well. This is a picture of ultrasound, intravascular ultrasound. So this is actually putting a little catheter down into the artery. Are you guys seeing this okay? Would it be better if it was darker in here? Maybe a little bit? I can do that, I think. Better for you. This might be a little bit better. And this is OCT. We're going to see some more pictures of that. But you can see how, you can see that little intramural hematoma, very normal there. The other thing is, as I've shown, SCAD isn't atherosclerosis. It can occur, but we are defining it in our research dissections that aren't associated with plaque. So people who have an atherosclerotic plaque can have a dissection related to that, but that's not who we're including. If we look at what we've looked at, about 80%, maybe 90% are women. About 10% are peripartum. If you'd seen the literature 5 years ago, they said it was about 30% peripartum. That's because they were making those diagnoses. What we're realizing is we were missing an awful lot of other folks, so that's decreased it. Folks with SCAD typically don't have risk factors, but they have different risk factors. It's also not rare. I'm sure you've been told by your doctors I've never seen this, or I was taught that this was really rare, and it is an uncommon cause of heart attack, but it may be the most common cause of heart attack in women under 50. And it is the #1 cause of heart attack around the time of having a baby. We do know that familial cases occur. We reported that, but that's pretty uncommon as well. And not enough is known. I think what's been gratifying to our team is we're seeing folks, we're seeing their records when they join the registry, and in the cath lab report, the doctor said, well, we've diagnosed SCAD, so they diagnosed it, and we saw that there was good flow, so we're not going to go in and do a stent. We're going to let it heal by itself because they know that now. And I think we're seeing increasingly, but we obviously need to get that out more. So I'm going to ask Dr. Tweet to come up now and talk a little bit about the role of imaging in SCAD.
So imaging is the predominant way of diagnosing SCAD acutely. And as Dr. Hayes mentioned, we did put together an article talking about this. And this is just a summary picture of the different types of imaging that we can do for SCAD and its diagnosis. This is a cartoon, but then over here it shows that SCAD patients often have coronary virtuosity. There's different types of narrowing that might help clue a physician that SCAD is occurring. We can use CT to look at SCAD, and we'll talk some more about that. Dr. Hayes touched upon using intravascular imaging, either ultrasound or optical coherence tomography. And then other modalities can be helpful as well. Echo, CT as we mentioned, cardiac MRI, nuclear studies potentially, and then other things to look at the vessels elsewhere. So what does SCAD look like on an angiogram? And many of you may know this, but this is a SCAD, or this is a vessel, and SCAD occurred, and there's this little slit here. And this is actually the contrast filling into that false area where the blood was going into, that false lumen. So this is one way that it can appear on angiography, and many times physicians see this and know what's going on. But sometimes it can be elusive and challenging. So here, you can see where those red arrows are. There's some narrowing, but you don't really see that slit that we saw on the other slide. And even here, there's some narrowing. Now, is that atherosclerosis or SCAD? In a SCAD patient, you can have intramural hematoma that does this without actually contrast filling into that false lumen. And we found that's one of the reasons why it may not be picked up upon all the time. And that's where optical coherence tomography is helpful, or intravascular ultrasound. If you're not sure, or the physician is not sure, in the cath lab they can actually look at the vessel, and you see this area where it's dark. That's actually blood and that false pocket causing narrowing of the true artery, which is in the center. This line you see down the center is actually the wire that they're using to guide the device. Again, this is an angiogram of a patient who was treated medically but had recurrent chest pain, and actually her SCAD kind of progressed and she lost flow to the blood vessel downwards. And this was her initial presenting SCAD, and this ended up being SCAD as we saw on that OCT, and then this is where the blood flow was lost. And there was progression. So the decision was made to stent in this situation, and something that we really want to highlight, good flow afterwards. This is the LED. But there were a lot of stents used. And it's just an important thing and something that we've been highlighting in our work. And as part of that, you can actually see still. So they did an ultrasound after that procedure. You can see the stent here. And then you can see out here the intramural hematoma. You can ignore the blue asterisk. That's part of the true lumen. But it's an interesting phenomenon because we've also noted that this can resorb over time. But that means the stent might actually be a little underdeployed. So this presents unique challenges that are different than from atherosclerosis. Now, cardiac CT can be useful for SCAD patients. It could pick up an acute SCAD, but the concern is as you get to smaller vessels, you may potentially miss it. And it's not always straightforward. This is a patient who had SCAD on the angiogram, and the arrows have kind of been displaced a little, but here is where the narrowing was on the cardiac CT, and this haziness to the left of it is actually intramural hematoma. So to orientate you, this is a CT of the heart, this is the aorta. Off of the aorta comes the coronary artery, so this would be the left main, the proximal left anterior descending artery, so the artery that feeds the left side of the heart. It's really narrow. For reasons of chest pain and some symptoms, a repeat CT was performed because the nice thing about this study is it can be non-invasive, so you don't have to do an invasive coronary angiogram. And here you can see that the blood vessel actually got better on its own with some medications and monitoring. And we think that many times that does occur, and it has affected recommendations made of how patients are managed. Some other interesting findings, so you can see, again, the SCAD on CT, and here you can see the split in the artery. This is just an example of what might be seen. So this is usually nice and smooth throughout, but you see those little dark lines through there. That's part of the wall from the dissection. And this is another kind of like 3D reconstruction. And usually the whole vessel should look like this, where it's open. But here you see that dark line through there. That's part of the wall from the dissection part. It can be challenging, and if, say, a radiologist or cardiologist interpreting the study isn't thinking about it, they may not do the reconstructions to really find it. But the reason why we highlight this is this could be a very important tool headed into the future. Some of you may have even had it, particularly if you're having recurrent chest pains, you're worried about another event, but perhaps there's not enough reason to go right to the cath lab. Cardiac MRI may have some uses too, specifically to get an idea of what's happening to the tissue. So here, I think that we can all appreciate the dark wall muscle of the heart. So this is the left ventricle here, and this is the right ventricle. This is the left atrium, and this is the right atrium. And here where those red arrows are, there's some whiteness there. I wanted to show it to you here. And then this is kind of splitting the heart like a piece of bread. This is the left ventricle muscle. The right ventricle is over here. And then as we get towards the tip of the heart, you can see that it's turning white. Well, what that white is actually contrast. It's gadolinium contrast that is being kind of hung up, so to speak, in the heart muscle. And that's consistent with areas of inflammation or many times scar from the heart attack. That can be helpful in certain cases. One, if a physician is wondering how extensive the heart attack was, or two, if the angiogram wasn't so certain, still thinking maybe SCAD, not really sure if there was an actual heart attack. Many times this can really give a physician an idea of what's happened to the heart tissue. As we kind of alluded to, many times after seeing hundreds of angiograms as part of the study, we look at all of them when they come in. We, in fact, don't enter somebody into the study until we've had a clear chance to have an interventionalist look at them, and this is usually Rajiv Gulati or Patty Best. And when we feel convinced that that is consistent with SCAD, then we'll go ahead and enroll patients. But as part of that process, in particular, Rajiv Gulati noticed that, hey, there's a lot of patients with kind of curly vessels. And when we look at that and compare that to the population without SCAD, it's much more common. And what we mean by that is the vessels are often kind of turny, so instead of a really straight artery, it's kind of twisted on itself. And we've noticed that, and that's been part of the interesting findings as part of this research, and we wouldn't have even known it without the registry itself. And so this is an example of how that kind of twistiness. Now, what is the significance? That's something we're looking at much more closely. Dr. McAleed has written a paper on it with our whole team, and there's some concerns about whether or not that can help determine where another SCAD might or may not occur. And there's a lot of things we're looking into, but just trying to understand why SCAD may occur is very helpful. There's a lot of things we still don't know as well. So these hearts, they're wild. They're torturous. But that's why we have ribs there, and that's why we're doing this research.
Thank you, Dr. Tweet. So she'll be back. We're all going to be back. So I think I want to transition a little bit into just briefly on treatment. And I think that one of the things I wanted to celebrate is that we have guidelines for heart attack. And they didn't differentiate SCAD. It was like an asterisk or a sentence. And the guidelines would say, get somebody in the cath lab within 90 minutes of chest pain. Well, I'd agree with that for SCAD. But then if you find they had a heart attack, you needed to put them on antiplatelets, do a stent right away, get that artery open within 90 minutes, and put them on a statin. And so I think that one of the things that this research has done is that the importance of the diagnosis, because all of these things may not be guideline-based for SCAD patients. Now, the one nice thing is in 2016 in February, there was a new paper that was a scientific statement that was about heart attack in women, and they had a whole section on SCAD, on SCAD, more than has been covered in any of our guidelines for we physicians. So they basically said SCAD's different and quoted a lot of our research, and it got it out there. And that is the currency of how your doctors learn about new things and new treatments. It is through reading medical journals. So we've alluded to the fact that maybe putting a stent or bypass isn't the thing that everyone needs, but it is certainly the thing that some people need. And so I don't want you to walk away from this, particularly if you had a stent or a bypass, thinking, oh, my doctor overdid it or whatever. You just saw a case where it much more depends in an individual with SCAD as opposed to somebody who has a regular atherosclerotic heart attack. So this is not a picture that we put, but it's one of those, a picture tells 1,000 words. And why, remember those tortuous arteries? That's one reason it's hard. So technically it's maybe harder to put a stent. So here on this side, you've got this artery and it's narrowed. That's the normal part of the artery. It's narrowed because of a long section of SCAD. And so they put a stent in. And what happens? It moves that intramural hematoma back up the artery and makes it very narrow. So they put another stent in, and that narrowing goes up. And now you've pushed that blockage all the way up back and perhaps to go down another artery. Now sometimes doctors are stuck between a rock and a hard place. But there's other options in terms of either seeing if that vessel might have healed on its own, or even perhaps doing bypass surgery. So we think we just need to make that diagnosis and make decisions at that time based on what we know. And here's just an example. There's a SCAD vessel that healed later. That was without any treatment. And over time may have gotten bigger. So we see that a lot. We are looking to maybe try to do a serial study using CTs to see, because I get questions all the time, probably from people in this room, saying how long, how many people, what's the percent of healing, and what's the time frame for healing? Well, without doing that prospectively, you can't do that retrospectively, without doing that prospectively, and perhaps doing a number of CTs or other studies on a lot of people shortly after their SCAD, we won't answer that, and that's one of the things we'd really like to do, that's a wish list. So I think in summary, one of the things we're trying to get out to your doctors is think SCAD. So think SCAD, if it's a young person, not a lot of risk factors, that artery looks a little funny when they do the angiogram, particularly if there's tortuosity and there is plaque. We also encourage them to do that extra step of doing OCT or IVUS if you're unsure. We don't do that a lot, actually. We've been looking at them enough, so we're pretty confident. And I think anytime you put something down one of those arteries, we're a little cautious. But it's so important to make the diagnosis that we're encouraging them to do that. And then to think twice about rushing to put other stuff down that artery, because if it might heal, if that individual might heal on their own, that would be great. Yeah. So talking just a little bit about causes, I think we've really evolved. We didn't know anything about what caused SCAD except a few very rare genetic conditions when we started this. And what we are coming to terms with is there's the vulnerable wall. So they may have a vessel wall, blood vessel wall. So it may be that there is fibromuscular dysplasia. We'll talk about that more. It may be that there is an underlying condition. It may be that there's other things, but then there's a trigger, because people go through their whole lives, and we've identified what some of those triggers are as well. So it's probably a bit of a perfect storm, and many of the patients we've seen, they talk about a lot of things happening at once. So when we talk about sort of buckets of causes, the one in the green, the collagen or genetic, that's actually pretty small, and we're finding it smaller and smaller, a definite gene defect. But there probably are some genetic contributions to folks. We know about the pregnancy and hormonal things. And in terms of pregnancy, it isn't the pushing that might contribute, because we've had individuals who have not gone into labor, who've had a planned C-section that have had SCAD. So it's probably more the hormonal fluxes. I say this because there's an awful lot of individuals who are very concerned. They maybe had a pregnancy-related SCAD, and then they're worried about hormonal, menopausal hormones. Remember that menopausal hormones are sort of replacement hormones. They're very, very low level. We don't recommend them for all people, but we're much less worried about that. But we do advise against oral contraceptives and a lot of hormonal manipulation if somebody's had SCAD. There's a huge bucket of other that we don't know, but one of the things that's really been reported to this group before is the issue of fibromuscular dysplasia or other vascular things. So it may be, it's our hypothesis that SCAD in a lot of people, not all, is a representation in the coronary arteries of something that's going on in the rest of the body. So this little diagram is in our patient ed to give you an idea of normal, and this is your arteries, the iliac arteries. They actually tend to go through either the wrist or the right femoral artery, so on the left side of the screen to do your coronary angiogram. And that's important because when we were reporting out on that first 87 patients and we looked at all of their angiograms, so this is an angiogram. So when your doctor goes in for an angiogram, he shoots a little dye to make sure that he's in the right place. Because you don't want to put a big batch of dye in the wrong blood vessel or something. And sometimes that gets recorded on the camera, sometimes it doesn't. And out of those 87, 16 of them had it recorded on the camera. And 8 of the 16 had fibromuscular dysplasia. No one had ever reported that before. It was a new finding, but it was really striking that half of the ones who had that. And so this is a CT showing some of that. So we set out to, as patients were coming to Mayo, so this isn't the registry, to do some imaging. And what we found is actually the majority of patients have either fibromuscular dysplasia or other abnormalities in other blood vessels. And so some of those are other dissections, and they may have been completely asymptomatic, because if you have a little tear in an artery that goes to your spleen or to something else, you may not have any symptoms related to that. Aneurysms, so these are some aneurysms that were picked up, just dilated, tortuosity of other blood vessels or other things. So we've reported that out, and some of that was related to the work that you have supported. So if somebody, this is just a clinical clue because, and it is out in writing, but we recommend, so if you haven't had this done, if you've had SCAD, we do recommend at this point screening for other blood vessel abnormalities. And that can be done with CT, we do it at Mayo with CT angiography, but MR can be helpful. And then we screen from here to here. If we find anything, we also screen the brain arteries. And then if we find anything else, then we can work through that. What we typically have found is fibromuscular dysplasia that does not need treatment. So it's minor, it's mild, and that's reassuring. And we've got Dr. Cohoon who's going to be telling us more about that and his plans. So for those of you who do follow my Instagram, this is not my dog. This is a dog I follow on Instagram, but it's a great terrier pics from Sweden. So anyway, I'm going to have Dr. Cohoon come up and talk more about our FMD practice.
Wow, thank you. This has truly been an inspirational day for me for several reasons. Number one, I want to thank the SCAD research for putting on today. If it wasn't for them and for all of you, we wouldn't be able to come here and enjoy doing the things that we absolutely love. In addition, this is inspirational for me today too, because I get to come and hopefully educate people about fibromuscular dysplasia in the hospital that I was actually born in and received my first stitches. And now I'm practicing up in Minnesota, so thank you. So with that, fibromuscular dysplasia, it's been reported that patients with SCAD can have up to a 45 to 80% concomitant fibromuscular dysplasia. So fibromuscular dysplasia is actually an arteriopathy that's non-inflammatory, non-atherosclerotic, which can affect multiple anatomic arteries of all sizes. These are typically dissections, which can be appreciated in up to about 20% of patients with fibromuscular dysplasia, or aneurysms, which occur in roughly about 17% of patients with fibromuscular dysplasia. There's also dilatation and tortuosities. Fibromuscular dysplasia affects several areas. Number one can be carotid or vertebrals, which is in the neck. Those are arteries within the neck. The coronary arteries in the heart, such as in SCAD. The kidney arteries, which many patients may actually have hypertension or high blood pressure from. Mesenteric arteries, so arteries that feed into the bowel, can have fibromuscular dysplasia that can dissect or have aneurysms and cause ischemia. There can be associated brain aneurysms. So aneurysms, roughly about 11% of patients may have associated brain aneurysms with fibromuscular dysplasia. And this is the importance of that multi-scanning from essentially head down to abdomen and pelvis. And then the lower extremities can be affected by fibromuscular dysplasia. This here is an image of a patient that had carotid artery fibromuscular dysplasia, and you can appreciate with the arrows there's these stenotic and dilatation lesions that are very representative for patients with FMD. This is an example of renal artery fibromuscular dysplasia. Again, there's dilatations and stenotic lesions, and these can contribute to patients' hypertension, which ultimately may be a reason for why patients have dissections in other arterial beds because of high blood pressure. This here is an example of fibromuscular dysplasia in iliac and femoral arteries. And I've heard several great quotes today, walking with many of you and talking with many of you for today. And one great quote that I've heard by one of my patients that I absolutely love is that there are doctors and then there are innovators. And we have many innovators here today, but we have many other innovators that are out there doing research just in this area at many other spots as well. And we're doing this within fibromuscular dysplasia at Mayo Clinic is really part of this innovation. We have developed a multidisciplinary collaborative clinical practice and a research program that provides specialized care for patients with fibromuscular dysplasia. The goal of our program is actually to advance the understanding of the underlying causes and the risk factors for FMD, and then develop solutions for optimal diagnosis, for treatments and prevention, and hopefully cure. We've built the most comprehensive multidisciplinary team to solve these problems by utilizing the most innovative solutions. We have incorporated people such as myself with vascular medicine training, vascular surgeons, cardiologists, interventional cardiologists, radiologists, radiology imaging specialists, researchers, PhD, masters, students. We've incorporated medical genetics, and our neurology colleagues, as again, brain aneurysms and dissections are a component of fibromuscular dysplasia. Our fibromuscular dysplasia program, it takes a novel approach by patient-initiated rare disease or uncommon disease, utilizing both registry participants, utilizing the data from participants, using genetic analyses based on novel database registries and DNA and plasma biobanking, and then taking that information and taking advanced medical imaging and other collaborative programs such as the SCAD program. It takes people to find links and associations that others may not see. And this is a group of the FMD innovators that really are looking for those links and associations with all of patients that either have SCAD or FMD. Again, there's potential connection between 40 to 80% of patients that have SCAD may have FMD, and we're still learning that. But again, it takes several people and multiple teams to hopefully find a cure. As a result, we're not just looking to try to solve the patient's problems for today, for tomorrow, but we're really looking to try to solve them for the years to come. The resources are at Mayo. The talent is at Mayo. Our dedication and devotions of the patient comes first has always been with us. And it's now our responsibility to come together to really succeed in making the impossible possible. So my highest hopes, and I hope I relay here, is that we all together can make a difference to help the world by transforming these technologies and innovating the future of medicine so we can make patients and grandmothers and fathers and sons and daughters better, healthier, and happier. So that's truly innovative to me, and it's truly inspirational. And I want to thank you for allowing us to participate in your day. And that's why I'm excited about our FMD and our SCAD program at Mayo. Just to let people know, I've left cards here that you can make an appointment with us in our FMD clinic. And also, if you would like to participate in FMD research program, that's available as well. Thanks.
So there's a little story about these M&Ms. They were on the candy bar for Ellen Robbins' 60th birthday. She had special M&Ms made. I took a picture of them because I knew it would be a great transition slide. So I wanted to, just as a springboard, so as we have been seeing patients at Mayo Clinic, we realized that, and in our registry, over time, we recognize that some people would say, oh, my aunt had a heart attack when she was 42. Or, my dad and all of his sisters had aneurysms. And so we said, at least in some of these patients, there may be some type of connection. And so we did report last year 5 families where we were able to confirm SCAD, meaning we were able to actually look at angiograms and know that they were 2 family members. But going beyond that, and it suggested a lot of things but raised questions because we don't know how they're connected. So I wanted to invite our PIs from the genetic program, the DNA Biobank, to talk about what they're doing so you understand it better, and we're really excited to hear them as well. So Jeanne Theis, please come and join us. Yeah.
Good afternoon. It is truly a privilege to be here to speak on behalf of the genetics team today. And I've also been very inspired to the point that my 8-year-old son convinced me to run a 5K that I was planning to walk. So. But yeah, no, but seriously, it's inspiration for me. It makes me want to honestly go back to my computer and start working harder, faster, and trying to find more answers for all of you here today. So today, what I'm going to do is I'm going to provide you with a little bit of a context of the genetics of SCAD. What do we know and what do we have left to learn? So since the beginning of this research program, our hypothesis has been the same, and that is that genetic factors underlie susceptibility to SCAD. So in order to address this question, we have 2 aims in place. The first is to create a DNA biobank for individuals with SCAD and their parents. The second aim works off of this, and that's to try to identify inherited and spontaneous mutations in individuals with SCAD. So long-term objectives, our dream, is to discover the biological mechanisms of SCAD, ultimately to develop tests and treatments to predict and hopefully maybe even one day prevent SCAD. And like I said, it's the dream. This is what we dream about when we're working on this research. So it's become a tradition, I think, the last couple of years, I haven't been here, but to show a map to show study participation. So there are currently 475 study participants in the continental US who have provided a DNA sample for the genetics portion. Impressive number. What's almost as impressive is the breadth of participation. You can see we're not clustered in one small area, and that's what all of you and the social media and the awareness you're raising has really done. So every state is actually represented with the exception of Delaware. It's the only one that is not on here. I like maps, I like visuals, so here's just showing a breakdown of the top 10 states as far as study participation. So Minnesota, Illinois, and California, this one here. But as you know, and I heard there is one international participant here, that this is not, because of social media, we're not confined to the United States, so we do have study participation worldwide. Many participants in our neighbor to the north in Canada, but also overseas, Australia, New Zealand, Italy, Netherlands. And again, here's just a map to show sort of the breakdown of those study participants. And again, all of these individuals have provided a DNA sample, which we have in our freezers at the Mayo Clinic. So where do we start and how do we begin to unravel the genetics of SCAD? It really begins with what I just showed you in that study participation, the willingness to provide a blood sample or saliva sample for the genetics portion. So to date, if you add up international and domestic participation, we just went over 500. So we have 503 DNA samples, over 90% women, 15% was recurrent, and the age range at the initial onset was 20 to 75 years. We also have parents of individuals with SCAD who, as many probably know, we're also recruiting, and I'll talk a little bit more about that in an upcoming slide, but we have 365 mothers and fathers who also have provided a DNA sample. Over the last 6 to 12 months, we've, as was mentioned, we've had a lot more family cases or familial SCAD come to light. So there are 8 families, and all of these families are participating and have provided DNA samples. So this is the language that we speak in our lab, but I just want to kind of translate it for you in case you're not familiar with pedigree. So square symbols are males and circular symbols are females. A line that's horizontal that connects them would indicate marriage, and then the line coming down branches out for the children. So the top 4 families or pedigrees that you see are all showing sister pairs, 2 sisters who have had a SCAD event. So to provide a little bit of context for how we're thinking about the genetics of SCAD, I wanted to provide, give you a little bit of context with 2 different blood vessel disorders which have very unique genetic basis. So on the left-hand side is Marfan syndrome, and Marfan syndrome is a connective tissue disorder, one of the features in many individuals being an aortic aneurysm. And what you see on that pedigree that's a little bit different is there are a lot more generations being shown, and there are a lot more colored symbols. So I didn't say that, but black symbol indicates affected and white unaffected. So this is very clearly a hereditary disorder as shown by the blue background. The mystery of Marfan syndrome genetics has been solved. It's due to a single gene in almost all cases. So if somebody goes to their clinician with Marfan syndrome, it's a matter of sequencing that single gene to identify the mutation or the variant that causes the disease. On the other end of the spectrum is atherosclerotic coronary artery disease, and Dr. Hayes showed you some of the really nice pictures here. So I'm also showing a little cartoon schematic showing the plaque buildup inside of the coronary artery wall. This is more thought to be due to environment, so high cholesterol, diet, things like that. So there's more of an environmental basis versus hereditary, which is why I'm not showing any families. I'm just showing a lot of colored symbols. There have been population-based studies looking at the genetics of atherosclerotic coronary artery disease, and essentially what these highlight is there are many genes, many different variants out there, and these probably play a much more minor effect, particularly when you compare to something like the mutation in individuals with Marfan syndrome. So where we use SCAD is right in the middle. We do believe that there is a hereditary component due to the fact that there are several familial cases out there. But we also, as Dr. Hayes also pointed out very nicely, think that there's obviously some environmental things that come along with it too. So things like pregnancy being an example. So we do know, I can tell you that there's not a single gene for SCAD based upon our preliminary studies, and I'll share a little bit more about that. So how do we begin to do this? What is the methodology and the technology we're using? And this is a technology known as whole exome sequencing. It's only been around and affordable for maybe the last 5 to 10 years that we've been able to do this. So, and what it does is it actually takes the DNA sample and it sequences all coding genes. So the 20,000 genes in the genome, it takes and it pulls those out, sequences them, and then annotates them for variation. So it begins with a sample, a blood sample or saliva sample. We extract the DNA. And then there's several multiple processing steps for that DNA to get it ready for whole exome sequencing. Once it's on the sequencer, it changes because the technology is getting better very quickly, but it takes about 5 to 7 days of just constant data collection. So the same samples sitting there and these computers are just collecting data files galore, and I don't even, can't tell you, I know it's like probably a terabyte, it's a huge data file. So we then work with our bioinformaticians to help us with that, so that we don't have to deal with that much data. And what they do is they do all of the alignments, so they have the human genome, they align all of these sequence files, and then they do the annotations, they annotate all the variants. And all said and done, the 20,000 genes has about 1 million variants per individual. So the challenge for us, this is where we come in, is to try to take those 1 million variants and filter them down to what makes sense for this condition. So we have a lot of different things in place. I'm not going to share all of them, but we look at the rarities. So how common is this specific variant in the general population? We also look at the deleterious nature. So does it look like this variant in this protein could be really having a bad impact on it? And that's what leads us to the SCAD susceptibility variants. So since Dr. Olson was here 2 years ago, sharing an update, we've had a lot of advances that we've made, and the first one is in the DNA biobank. So in 2014, we had DNA samples from 291 individuals, and now like I said, we just went over 500, we're at 503. Parents of SCAD participants, that's also doubled, more than doubled, so we had 176 up to 365, and then familial SCAD, this I've also highlighted. We've also done more sequencing, so we've gone through this whole exome sequencing process with more individuals, so we've almost doubled the number of SCAD participants that we've done whole exome sequencing on, so we're up to 50, and done several parents as well. And then the gene filtering, this is really the tough part of this, is trying to take and find what's important in all of those variants that come out. So population control sequences are important. These are controlled populations who have undergone whole exome sequencing. And this is where we can look, if we have a specific variant that we're really intrigued by, we can look and see how common is it in the general population. If it's really common, we're probably not going to look too much further. If it's unreported or never been seen, we might think again about it. Back when Dr. Olson was here, there were 6,000 control sequences. There are now 60,000, tenfold increase. And this is partly due to just the technology is racing. It's going so quickly, and the prices are coming down so it's just a lot of things happening at once right now. Genes specifically expressed in the coronary arteries. This is another feature that if we can look at variants or genes and say which genes are expressed in those coronary arteries that could make them susceptible. Back in 2014, this was a complete unknown. We couldn't take a gene and know if there was expression in the coronary artery. But now we do know this. There are databases, there are technologies that have basically looked at the coronary artery and identified the genes that are expressed. And so this, again, is a huge thing that is probably within the last 6 months or so. So this is another advance. So to talk a little bit about our pilot study design, we now have 50 individuals who have undergone whole exome sequencing. And we have a dual strategy approach in place. So the first is family-centered, and that's why we are as a part of the protocol, have mothers and fathers who are looking for samples. And the reason for that is because we can look at the family unit, look at mother, look at father, and look at the individual with SCAD, and look for variants that are maybe not in mom and dad, that are in the individual with SCAD. Or maybe in the case of familial, look for a variant or variants that are shared, and maybe they have a higher burden of a specific variant than mom and dad. So those are the things that we're looking for with our family-centered approach. The other approach, and so this was looking for inheritance of a unique gene. The other approach is case control. And to do a case control study, it's really dependent on numbers. The more numbers you have, the better, because you can draw more information out, and the data can speak louder. So here, we actually are focused more on looking at individuals that are affected with SCAD, looking and filtering those million variants down to those that are rare and don't look like they would be so good to have around. And we compare those variants to people that have not had a SCAD disease. And here what we're looking for is enrichment. So we're looking for enrichment of the same or related genes, regardless of whether they're inherited. So it really removes the family-centered piece from it. But we're looking at both, so we're using both approaches here. So preliminary findings, I've alluded to this already, but unfortunately, so SCAD has genetic heterogeneity. There is no common SCAD gene. You can't, if someone has a SCAD event, there's not a gene that can be gone to see what is the variant. Also, aortic aneurysm and dissection is non-unique to SCAD from a genetic perspective, so we have looked at those commercially available genes for other aortopathies, and there doesn't seem to be a correlation there. But what I can share with you is that we do have several candidate genes, so from the pilot study that we're looking at. And there are actually 2 genes that fulfill stringent dual strategy filters, so they fulfill both the family-centered and they fulfill the case control. And they're also very highly expressed in the coronary arteries, and I just have a cross-section here showing that. So what are we doing right now? We are actually working on validating those top 2 candidate genes. And the way we're doing this is doing a gene-targeted screen in our remaining 453 study participants who we did not do whole exome sequencing on. And we're also really looking at trying to correlate genes and SCAD subtypes, so pregnancy, recurrence, fibromuscular dysplasia, and due to the beautiful registry that's put together, these are things that can be looked at and looking, is there a certain set of genes that's cropping up in this group versus that? So we're really trying to further dissect that out and thinking about that differently. So what is our ultimate goal? Well, our ultimate goal is to perform whole exome sequencing of all the participants. So again, another pie chart for you to end. So we've performed exome sequencing on 50 individuals, which is 10%. And looking to do the remaining 90%. And with your partnership, and we're excited that this could be something that we can do in the future. And we truly believe that this will bring us another step closer to being able to understand the genetics of SCAD.
I want to say that I wanted to remind you that extra, the group that had been done since 2014 was all money from SCAD research. So I'm going to end with just a few, and then we're going to do some Q&A, but I want to leave you with a little bit about our clinical practice, and then also a little bit about some of our other hopes and dreams and updates. So really the fact that we set out to do a virtual registry, I told you that, but we've ended up gaining even faster because of people who come to Mayo who then we can actually talk to, we can ask those follow-up questions, we can review even more of their records and have that in the context, and then do our own tests, which is imaging. So a lot of that, as you can see, we've learned not just from the registry, but for folks who've come. Prior to 2010, only about 10 or 12 patients a year came to Mayo Clinic with SCAD or were diagnosed with SCAD, and now that's about how many per month. So it does allow us some additional learning in that regard. What do we tell all of our SCAD patients? One, the benefits of cardiac rehab. I think that one of the things we know is that cardiac rehabilitation, women are less likely to be referred and are less likely to attend. Well, that's most SCAD patients. And so I put in a plug now, and even most insurance companies will cover rehab, even if started within the first year after a heart attack. So that's something to spread the word about. I think it's a huge impact because my hypothesis is why some people with SCAD don't get referred to rehab. They said, well, you just ran a marathon last year, you probably can go walk, just start doing stuff on your own. How many of you heard that? Probably. But there's a whole lot more that goes on to rehab, and that's learning to trust your body again and dealing with the psychosocial issues. So I'd encourage that. In general, we recommend aspirin, and then there aren't really any other SCAD-specific medications that we currently recommend, but some people need other medications because of stent, because of heart failure, because of other things, and so that they need to go about. We don't recommend routine statin therapy, so that's cholesterol-lowering medication. We recommend it if people have elevated cholesterol, but in looking at our data, we don't see that it prevents SCAD heart attacks. I reserve the right, because I'm a statin fan for my atherosclerotic patients, I reserve the right to say if we see a benefit for SCAD patients, but right now, a lot of young people being put on medications that right now we don't see a benefit. A lot of folks have chest discomfort after SCAD. Some of it is non-cardiac. It's being very aware of one's body. Some of it's related to perhaps a narrowing in a stent or something that needs to be dealt with. And in others, it's clearly cardiac, but it's not a fixed problem. It's relieved with nitroglycerin. So we think that the artery may, during the healing process, spasm down and occasionally decrease flow. So we have found that nitroglycerin in a long-acting form or other drugs that relax blood vessels can be very helpful. So that's something that does, but aside from aspirin and rehab, the rest are very individualized. This question always comes up about pregnancy. So the current guidelines for people with SCAD is that people don't get pregnant because of the known association with pregnancy. That said, that is a devastating thing to tell to a 25-year-old unmarried woman who you just told you should not have children. So we know that patients with SCAD have had children and successfully had that. We're very cautious, and we physicians feel very, because we don't know how pregnancy induces SCAD or is related to SCAD, it's hard to know, and so we're scared because we know that something might happen. I think the goal is, if you look at the data, and this is something, we've got actually more folks in this, but we had 8 patients, and out of 8 who took a pregnancy to term, 1 had a recurrent SCAD. It's about 12%. We also know that 7 did fine. This is a serious issue that we're working on and trying to sort out, because it may be that there are some SCAD patients that once they've got their cardiac issues settled down, there is no excess risk in having a baby. And for others, there's very high risk. And it is this research that will help us be able to separate those out. Obviously, if people are pregnant, their cardiac status needs to be evaluated, and they need a team of physicians caring for them. But again, I don't want anybody walking away that we're telling people that it's okay. We're very cautious about that. And we're working with some of our maternal fetal medicine folks to help us with further assessing it. We've talked about a number of these things. I'm going to, that often come up, and we can take questions about these during Q&A. I think one was a question that was sent online or in advance, and I will take that question. So it's about physical activity limits. As you know, many folks with SCAD, and many in this room, one, had a high level of physical activity, whether it was marathoning or triathloning or just doing things that were very physically active. And since we, remember, we've got maybe people with SCAD have more fragile blood vessels, and that extra stress may cause or trigger a SCAD in that perfect. So the question was an individual who was actually has a competitive athlete, had won awards for their competitive athletes. And the question was, is there ever a scenario that I might be able to return to that level of exercise? And I think possibly. But because, for the same reason we can't identify those individuals who might be at much higher risk for pregnancy or not very much risk of pregnancy, the exercise thing we also don't know because it's a known association. And it's probably a stronger association among men than it is among women. And so what we recommend is that people do aerobic exercise, moderate intensity aerobic exercise. Somebody asks, can I run a 5K or 10K? I say, yes, I prefer you don't race it because it is that intensity, no weight building and other things. So I think staying tuned in us being able to provide more prognostic information about pregnancy, about exercise, about a lot of those things, so we can, because with atherosclerosis, we've been studying that a really long time. So we're able to take an individual with a certain set of risk factors, behaviors, and genes and say, you're at very high risk, you're at much lower risk. We're not there for SCAD, but that's one of the goals of this research. So, to wrap up, we're going to see more, we're already seeing more SCAD, not necessarily because there's more SCAD, because we're recognizing it. I say we, collectively. I'm always happy when somebody calls or they send an angiogram and they say, I think I saw another one, let me send the angiogram for Dr. Galati or Dr. Best to look at. We welcome that from your doctors as well. We continue to pound on that the correct diagnosis needs to be made. We hope to do a community-based prevalence study because we know when we talk about research, one of the things that's really biased, if you collect all your participants from kind of the same place, like Facebook, where it's 80% women anyway, you may bias your sample toward or away from people that you need in your research to really get the answers. Referrals remain really important, so if you run into other SCAD patients, I think one thing we're excited about is that probably in 2017, there'll actually be, remember I said the first women's heart attack guidelines of American AJ scientific statement came out earlier this year. We're hoping for one on SCAD. It's been approved by the American Heart Association. And I want to show you how we're collaborating, we at Mayo, with many other folks. So this is the group who will be on the writing group. Obviously Mayo Clinic is well represented. I'm chairing it, but I've got co-chairs from Cleveland Clinic, Dr. Esther Kim and Dr. Jacqueline Saw, who's published extensively on SCAD from Vancouver General in Canada. And we've got Duke, 3 folks from Mass General, we've got the UK, we've got geneticists, nurses, we've got cardiologists, interventionalists. So what we will be doing, this is not research, but it's important because one of the things I know you all want is you want to get the word out. So whenever the American Heart Association believes that there's enough data out there to warrant having a statement, then what this group will do is they'll go through all the literature, all the way back. We'll synthesize it, and then we'll write what is the state of the art for that time. And once we start, the clock has not started because we need one more member to our group, and we're getting an OB-GYN on our group, which I think is very important for this. And once that, the clock from that is about a year for publication. So stay tuned, maybe we'll have that next year. So we're taking a bunch of deeper dives. We mentioned a lot of these things, and some of you asked where else, do you ever want a tip on, for fundraising or anything? Research costs money. What we do, the tests and the things, so the more, if you have a connection, talk to Bob, talk to me, depending on SCAD research, and know that we are applying for every grant for which we are eligible. And we'll continue to do so. So these are some of the folks. The cardiology division has supported Dr. Tweet and I incredibly through this because without certainly some early help that was where we had no funding and just wanted to take this forward, we couldn't have done it, and certainly we appreciate we could not do it without SCAD research and the survivors. So with that, I will invite the rest of our speakers up and ask for any questions from the audience, and because we've got live streaming, we will repeat the question. You're going to tell me to do that one.
I would say everybody to tell everyone that we are live streaming.
And we are live streaming. And that's what, I guess that would be, thank you for reminding me. The question was asked, is it okay to live stream the questions? And I said, it's fine with us, but I would remind you that that your questions will be recorded, so if it's something, I'm not going to get into personal details, but perhaps you might want to think about that as well as you move forward. So I'll have you guys come up so you're close to the mic, and do we have any hands raised? Okay, we've got that.
Would you elaborate more on the exercises? I think I heard you say not weight building, and would you elaborate on what you mean by that?
I would be glad to. So it was elaborate on the physical activity and weight. So not weight. So we definitely want people to do resistance exercise and strength training. The idea that some people were told previously, don't ever lift anything over 10 pounds. Well, imagine you just had a baby, even Rebecca, I think, probably weighs definitely more than 10 pounds. So and to tell a 25, 30-year-old woman, don't ever do any strength training, she's going to be falling over, breaking bones when she's 60. So what we mean is not weight, like weight training, meaning training to weight lift, to body build. So we usually recommend 10 to 20 pounds max, but frequent repetitions. So you can stay pretty